You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for April 19th, 2019. This week, embolic stroke of unknown source, sugar-sweetened beverages, AFib knowledge, LDL and brain bleeding, and genomics. First topic is embolic stroke of unknown source. It's about 1 in 5 ischemic strokes have no obvious source. So the therapeutic dilemma is preventing another stroke when you don't know the cause of the first. Two relevant facts here. AFib is often asymptomatic, and rivaroxaban has shown promise in treating vascular disease. Consider the COMPASS trial, for instance. Rivaroxaban, therefore, should cover both possible causes of ESUS, emboli from AFib or vascular events. That's why it was a surprise that Navigate ESUS, an RCT comparing rivaroxaban to aspirin in patients with ESUS, was stopped for futility, no benefit. So, before I tell you about the latest JAMA neurology study, we should take a moment of pause here to recognize the benefit of evidence, namely, plausibility pointed to rivaroxaban working in these patients, but then the RCT showed it not to be the case. Just because things should work doesn't mean that they will. Now, onto the JAMA paper. This was a secondary analysis of the Navigate ESUS trial, which examined about 7,000 patients. The authors grouped the patients by clinical predictors of AFib, which were LA diameter, frequency of PACs, and then they used a composite score of clinical features called HAVOC, H-A-V-O-C. And this is a composite score like the CHAD score, and it uses 7 clinical characteristics: hypertension, age, valvular heart disease, peripheral vascular disease, obesity, congestive heart failure, and CAD. Now, recall that one of the reasons the main Navigate ESUS trial may have been negative could have been the low number of patients enrolled who had atrial fib. So the point of this secondary analysis is, what if we look at patients with a high risk of AFib, those with other evidence of left atrial disease, then in those patients, rivaroxaban may be successful. So the researchers found that the detection of AFib during follow-up increased for each tertile of HAVOC score. However, neither of these tertiles of the HAVOC score nor premature atrial contractions frequency influenced the association of rivaroxaban with recurrent stroke. The P4 interactions of these associations were negative. Not surprisingly, increasing LA diameter and increasing PACs associated with an increase in AFib incidence, but only the group of patients with the left atrial size greater than 4.6, which was about 9% of the main trial population, had a lower risk of recurrent stroke on rivaroxaban versus aspirin. So the take-homes. First, this is an exploratory analysis of a trial that did not meet its primary endpoint, so caution is important. The main finding, too, here was that the lack of consistent benefit of rivaroxaban in patients at greatest risk of AFib. The one positive finding, that in the group of patients with really large left atrium, rivaroxaban use associated with a lower stroke, is indeed plausible, but could also be due to the play of chance. Thus, this study should definitely not change practice. We should not begin recommending DOACs for ESUS, but the findings are interesting, and I think the authors are right to speculate about expanding our risk prediction to measures of structural atrial disease. Remember, the electrical AFib episode on the ECG may only be a surrogate marker of structural atrial disease, and that atrial disease, if it's severe enough to predispose to embolic stroke, may not always present with electrical AFib. And perhaps this is why there is such a poor temporal correlation with AFib episodes and stroke. The next topic is on sugar-sweetened beverages and the government's role in public health. You can love liberty, you can advocate for less coercion, and still believe government has a role in protecting the public's health. For instance, government should help provide clean drinking water, they should ensure safe structures like bridges and buildings, and also provide some smart regulations. One such smart regulation is fair labeling of substances the public may want to know that they are ingesting. Say, the added sugar in sugar-sweetened beverages. Yes, we live in a free society, and people should be free to consume sugar-sweetened beverages. That's fine. But excess sugars, especially from these sugar-sweetened beverages, contribute significantly to cardiometabolic disease. In 2016, the FDA mandated the labeling of added sugar content on all packaged foods and beverages. But, quote, due to industry concerns, government delayed this compliance. Of course, the industry's concerns are that telling people the truth about how much added sugar is in these drinks will reduce unit sales, which would be good for the public but bad for industry. So when it comes to health and profits for junk food makers, there is no confluences of interest. It's all conflict of interest. What's not known, though, is the impact of such labeling on the public health, and so researchers from multiple groups performed a micro-simulation model to estimate cardiovascular and type 2 disease cases that would be averted. To be fair, the methods of this paper that was published in Circulation are way, way over my head. But the number of cases of heart disease and diabetes that were averted from this labeling change, at least that's predicted in this micro-simulation model, are in the hundreds of thousands. So I agree with the author's conclusion that labeling could provide substantial health gains. And unlike taxation of junk food, which is complicated politically and practically, telling people the truth about how much sugar they are consuming seems like a no-brainer. While many people will not change their consumption if they know how much sugar there is, some people will. So this seems to be a very small and minimally coercive nudge that's worth doing. Next topic is on the patient's perception of risk from AFib. One of the main things I do as an AFib doctor is remove fear. Now, how do I do that? I use information. My experience is that many patients overestimate their risks from AFib. And this is important because fear sets the stage for overtreatment. I mean, fear just crushes decision quality. So researchers from West Virginia University set out to empirically measure this fear. Mayo Clinic Proceedings published a survey study of 227 patients with established AFib in their clinic. Patients were asked to estimate their stroke risk without oral anticoagulants and bleeding risk with oral anticoagulants using a quantitative risk scale. The authors then compared these predicted risks with the CHADS-VASc and HAS-BLED scores, and they found that most patients overestimated their risks of stroke and bleeding. Over half the patients perceived an annual stroke risk greater than 20%, and also over half perceived an annual bleeding risk with oral anticoagulation greater than 10%. Most patients also perceived that oral anticoagulation would reduce their annual stroke risk by at least 50%. These overestimations are modest but important observations. I'm glad the authors wrote this up, and I'm glad that Mayo Clinic Proceedings published the study. One of the emerging roles, I believe, of the modern-day clinician is in translating evidence so that patients can make better informed decisions. Steve Stiles, a journalist at the Heart.org and Medscape Cardiology, has a super write-up on this topic. He quotes Professor Daniel Singer, who points out that there are clear benefits from oral anticoagulation, especially in patients with elevated stroke risk. But Dr. Singer also emphasizes the net benefits in absolute terms is smaller than most people think. I also love the comments from Dr. Deirdre Lang. She emphasized the importance of giving people time to make up their mind. Benefits of oral anticoagulation, remember, accrue over years, not a day or two. So I agree with Dr. Lane. I often give patients time. I say, go home, think about it, and call me back. Let me know what you want to do. I also like this topic because the disruptive thing here is of having a well-informed, non-fearful patient may be that she or he makes choices that we don't agree with, and that is okay in shared decision-making. Next topic is brain bleeding and LDL. So in the clinic, I see a lot of older women who have atrial fibrillation and have no vascular disease. Then I look at their medicines. Boom, they're on a statin. Then I look at their LDL, and many of these patients have very low LDL levels. So I shake my head and I think to myself, John, you should probably deprescribe. But then often I think better to stay in my lane because it's really hard to deprescribe statins in my community. So the previous data on the association of hemorrhagic stroke and LDL levels is mixed. Most of the statin trials, like so many cardiovascular trials, truncate after a few years. Concern over the long-term exposure to statins and very low LDL levels should not be dismissed, however. So a Harvard research group, publishing in the journal Neurology, attempted to study the relationship of lipid levels and brain bleeding using long-term observational data among the nearly 27,000 women enrolled in the Women's Health Study. Now recall that the Women's Health Study was an RCT of low-dose aspirin and vitamin E for the primary prevention of cardiovascular events and cancer. That trial ended way back in 2004, but observational follow-up of willing participants still remains. So the researchers had a mean follow-up of 19 years, and they found 137 hemorrhagic strokes. So then they went back and they looked at the LDL levels in those patients. They found a U-shaped relationship. LDL levels that were very low, less than 70, had a higher risk of brain bleeding, but low, moderate, and normal levels of LDL did not increase risk of brain bleeding. And then again, those with high LDL levels greater than 160, again, had a higher risk of brain bleeding. In the very low LDL group, those less than 70, compared to the LDL 100 to 130 group, the risk ratio was 2.1, so twice the rate. The researchers also found an increased risk of hemorrhagic stroke, specifically subarachnoid hemorrhage, among those with low triglyceride levels. Now, of course, the authors were cautious, rightly so, in their discussion. This is a post hoc subgroup analysis of an observational study, so residual confounding is likely. What's more, the research team only had the LDL at baseline to go from, so they don't know anything about changes in LDL through the follow-up. Keep in mind, too, that this was a study just of LDL levels and brain bleeding. Less than 5% of the patients in the main trial were on statins. Nonetheless, we have to talk about statins because these drugs are a common reason why people are exposed to very low levels of LDLs for a long time. So the authors contrast their positive associations with previous studies, and they cite two big meta-analyses of statins. One meta-analysis included only RCTs, another included RCTs and observational data, and neither of these showed an association of statins with ICH. They also cited the Fourier trial, an RCT of PCSK9 inhibitors that resulted in very low LDL levels. Again, no signal of brain bleeding. But crucially, most of these analyses incorporate studies with short duration follow-up. What does long-term exposure to low LDL levels do? Could it enhance age-related blood vessel disease? I'm asking, I don't know. I cover this story because long-term data on statin use is always relevant. Also, consider, just clinically speaking, if an elderly person has no vascular disease and is on a statin and the LDL is very low, this seems like a great opportunity to reduce pill burden. Finally, I want to leave with this final comment. Even if statin-induced low LDL levels did slightly increase the signal for ICH, we have strong data showing that the drug reduces strokes and vascular events. And here I see an analogy to oral anticoagulation for AFib. We know that antithrombotics do increase the risk of intracranial hemorrhage, but this small absolute risk increase is far outweighed by the benefits of the drug. So I see it's potentially similar with statins. Final topic today is predicting cancer therapy-induced cardiomyopathy. We know that high-dose anthracycline therapy or combination chemo with trastuzumab can cause cardiomyopathy. A new study, though, published in Circulation, demonstrates an increased prevalence of gene variants that are found in dilated cardiomyopathy in adult cancer patients and pediatric AML patients who had cardiomyopathy from chemotherapy. The gene variants involve regions coding for the protein titin, which is the largest protein in the human body. Abnormalities in the titin gene were found in 7.5% of cases of chemo-induced cardiomyopathy versus 0.7% of healthy volunteers. Now, the researchers added support to the association with an animal experiment. Here, they created a mouse model of chemo-induced cardiomyopathy. And anthracyclines induced protracted LV dysfunction in mice with gene variants in titin regions, but anthracyclines did not cause LV dysfunction in wild-type mice. So the clinical implications of this study are obvious. It may be possible to identify genetic risk factors for chemo-induced cardiomyopathy before it happens. And perhaps this will lead to studies of using cardioprotective drugs or cancer regimens tweaked to avoid cardiotoxicity in these patients. Previous studies on the use of cardioprotective drugs in general with chemotherapy have not produced clear benefits, but maybe using these drugs in a genetically prone patient population would deliver positive results. While this is an elegant study, it's important to point out its limitations. For instance, the study used 2 select cancers, breast and pediatric AML. Do the results generalize to other cancers? Nonetheless, the idea of identifying high-risk patients before giving cardiotoxic chemo seems like a great place for further work. One note before I close, This Week in Cardiology will take a week off. Next week, I'm pleased and honored to be going to the Portuguese Cardiac Society meeting, and I'll be giving a lecture on the external validity of clinical trials. So I'll see you in 2 weeks. As always, I'm grateful that you listened. Thank you. And if you like this podcast, please consider subscribing and giving us a review so that others can find us. I'll see you in 2 weeks. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.